Right, hello everyone. I'd first of all like to say thank you to Amy and Curly for inviting me to come and chat to you tonight. I'm always really impressed when people give new things or dare to give new things a go. And the motivation and incentive is great because it does. It one, benefits all of us where we struggle to get access. It brings people together. But also there's a huge amount of experience and knowledge within the area that we work in: hospital, community, medicine, remote area, ambulance, and so on and so forth. I've learned heaps in the last 3.5 years that I've been here. As a brief introduction to me, for those of you who don't know me, my name's Paul Reeves. I've been in EMS now. This is my 25th year. And I only wear the glasses and colour the beard in just to convince you that I am that old. I've worked in sort of various different areas from that. Originally started in the UK, so very developed health systems, and then spent a fair amount of time, last 14, 15 years overseas in remote conflict, post-conflict environments, so on and so forth. Sometimes part of teams, sometimes solo. So that's sort of given quite a bit of exposure and experience. And in most cases, when I've gone to a new program, project, country, or whatever, to a large extent, I felt out of my depth. So I'm very familiar, despite being an old bloke, of still remembering what it's like to feel out of your depth. And to be honest, you know, it never goes away. So the talk tonight is just a bit of an overview of sick kids, because they're probably one of the things as a paramedic, whether you're senior or junior, that can strike a bit of terror, make you feel a bit uncomfortable, and so on. And I have memories of prior to becoming an ICP back in the UK, so, you know, pushing on for 20 years ago, where I had my first really sick kid who I didn't really recognize and who didn't survive. And she was the age of my 3-year-old son at the time. And so that really, you know, struck a note. And this was an inter-hospital transfer, so it was a catalogue of not necessarily picking up on that. But essentially, when we delivered to the peds ward, the senior sister there recognized the gravity of the thing, and things started happening very, very quickly. I've since done a number of, increased my training, always looking for gaps to try and fill in, to try and learn from, whether it be from discussing cases I've dealt with, trying to figure out what's going on, do short courses. And in 2000 or 2002, I became a pediatric advanced life support instructor. So one of those national courses in the Australia, we have APLS, Pediatric Life Support, great courses just like ALS. Give a structure, give a starting point, have a common language. And some of what I'm going to discuss here is basically formatted on those same principles. So there's nothing sort of remarkably new. You're all of a similar grade, so we do have time that I'm going to try and stick to and often fail horribly. So I'm going to push through that and give us a bit of time at the end for some questions as well, hopefully as you feel a bit more comfortable to do so. Right, okay. So when we're addressing and looking after or thinking about children, they can conjure up a mix of emotions, from sort of soft, gooey, gaga type of thing to, as I mentioned before, abject terror. They can seem extremely alien, whether you're just in the presence of somebody you do not know and they have a small baby, or whether perhaps it's your own for the very first time. They're a completely different entity in many regards to what we now are most familiar with as adults. We largely have forgotten our experiences as children, what life was like, what we thought, what we felt, what things made sense and what didn't. And so despite being babies and children ourselves, that valuable insight has just vaporized. And now as adults trying to look after a worried, sick, scared, or just difficult child, it can be really hard to try and find or remember what the cues and tips and the things that are going to work and what doesn't. But it can be quite awe-inspiring. And one of the things that you that strikes you, particularly with small children, infants, babies, and so on, is just how tiny and fragile that they appear to be. So, one of the things that they do really, really well is take you from sometimes this position of tranquility and relaxation, and within a few moments, perhaps with even a first look, to accelerated and extreme terror. And the process or the purpose of a lot of the short courses that we deal with is to try and actually give ourselves a bit of a structure and a bit of a process when things do feel quite terrifying. Because our brains don't work very well under high stress. And they don't work at all if we want to try and work out complicated sets of actions and challenges. So, what is the big deal about kids? So, the main thing that when we have a look at them is that they seem remarkably different. Sorry, now some of this slide is not projecting. They're supposed to be words. Okay. I'll wing it. So the main difference with regards to children is that they're a different shape and size to us. So sometimes we think, well, they're not small adults, okay? And that's true, okay? That the differences in size, even within the age range of what constitutes a child, varies hugely. So from newborn and infant through to 6, 7, 8 years of age, there's a huge variation. There's a huge rapid acceleration of learning, development, growth, and so on. And it's all very different from the adult creature that we are most familiar with. Proportionately, they have differences. So they have smaller airways. Proportionately, they have anatomy that is different. So although they have tiny airways and tiny tongues and everything's small, proportionately their tongues, for example, are larger than ours within the oral cavity. So it challenges and things like airway obstruction and airway positioning is a lot more crucial, perhaps in a small infant, than it would be in an adult. All that said, the airway is no less important in either group. Metabolism is one of those things. They have a high burn rate, so they have low reserves. They will desat, they will become hypoglycemic, they will fatigue, and they will drop off this apparent wellness curve really, really quickly. They will give you less warning and less signs than the adults that we are more comfortable or more familiar looking with. And one of the reasons for that is that fortunately we don't have to deal with sick kids that often. They're not that common. Generally they are a healthy population who get sick or get injured. They don't have yet or haven't had the time to build up the exposure to chronic disease and all the problems that deals with, which actually forms a healthy part or a large part of the workload that we deal with in first response. One of the things that they're great at is adventure and misadventure. So you turn your back on them and they will get up to all sorts of mischief as they explore their new world. And in accidental injury, it's quite common for just a comment to say, I had no idea they were able to climb up onto that, to climb up onto something and fall out of a window, to fall downstairs and things like that. So as we know statistically, that the leading cause of death is in the adult population above 44, mid-40s, is heart disease. Below 44, and essentially from the moment we become mobile to about our mid-40s, it's trauma. As soon as we can actually start to walk, crawl, we climb up and fall off things, walk in front of things, and so on and so forth. We pick up and put random stuff in our mouths and drink things just to experiment and see what it's like, having no idea of the hazards and dangers that we deal with. But one thing they do brilliantly is lie. Okay, they are exceptional liars. That's slightly not true, but what they actually do is hide. They will hide and mask how sick they are. They will give you the impression that they're not that bad and harbour sinister, horrible ongoings internally that won't reveal themselves unless you know where to look until a time when you will be struggling to pick up the pieces. And I think that's one thing just to bear in mind, that they don't look too bad. Put that to one side. Why are you there? Why have you been called? What's the concerns? What's going on? Note what you know. What don't we know? And sometimes it needs to be given a bit of time, but having a structured and a basic workup will give you so much information. And what we're going to go through is just actually helping with some of the decisions to act and what category we put it into. Now, although I said that, and a lot of people will mention that children are not just small adults, when it comes to dealing with a sick, either medical or trauma, pediatric patient, we treat them just like adults, in the sense that we follow the ABC principles, or in trauma, the CABC principles of catastrophic hemorrhage, airway, breathing, circulation, so on and so forth. And that's a good thing, okay, because we get that. And whoever first thought of using the first 5 letters of the alphabet to treat emergency patient is just genius. Because if we're going to remember anything in that sort of adrenaline-fueled haze, perhaps it might be the first 5 letters of our alphabet that we learned so many years ago. So that's the priorities of management that we're going towards. Just a very brief mention on cardiorespiratory arrest. Okay, so what we're not going to be going through is resussing of arrested children in this short talk. But the things to note is that the majority of pediatric arrests are secondary cardiac, so their heart stops because of another reason that's not cardiac. Statistically, in the adult population, the common cause of an adult cardiac arrest is primary cardiac. There's a problem with the pump, often an MI, and they've gone into a fatal arrhythmia. Okay, so that's the numbers game from there. And so what happens is that the reason this heart stops is that it's been subjected to either a respiratory or a circulatory challenge, and perhaps a joint circulatory, a respiratory circulatory failure, and that has led on to this cardiorespiratory failure and cardiac arrest. As a result of that, if the heart stops because of those things, the chances of getting it started again are a lot harder, because you have to undo what's happened before, as opposed to the sudden VF arrest, collapse. Patient has a percentage or a good percentage of oxygen in their body. We do a bit of buy time whilst we get the gear on, we shock them, and that fixes the immediate problem, and we get good results. That isn't repeated in the general pediatric population. However, if you can pick up, as with any patient, adult or ped, in the peri-arrest setting, that's where we can really do our most good. In any patient in cardiac arrest, and although there's a lot of focus in trying to resuscitate patients who have died, the numbers of success are extremely small. And if you were going to focus on what we can do, then we're focusing on the patients who are really sick, that are likely to die, and try and turn it around while they can fight with you and your assistance you're giving them. Whether that starts as the first responder, the paramedic, the ambulance, into the ED, ICU, and turn it around with that process. That's the patients really that emergency medicine focuses on. The ones that arrest and then try and access emergency medicine don't fare well, mainly because of time. Okay. However, one little last note with this is that there are some kids who do have a primary cardiac cause. There are children who may present into a VF or a VT arrest. There are children who may have presented in a PEA arrest who go into VF or VT. So the arrhythmia management in pediatrics is very much there. And that could be your only experience, because pediatric cardiac arrests are not that common. When I spent a couple of years as a resus officer in a general hospital in the UK, we were on the crash team, so adult trauma, medical and pediatrics. And there was about over a 2-year period, you had 6 or 7 pediatric arrests that were brought in by ambulance, and most of those were primary collapses in the playground or at a sporting event, and it was some form of either known or unknown congenital defect in the original rhythm, or there was a shockable rhythm at some point in time. So you always need to be prepared for that and not fall into a slight trap of thinking we don't need to know about defib in kids. Okay? Right. So this is the process that leads to cardiorespiratory arrest. Patient may experience compensated respiratory failure or compensated circulatory failure, and their efforts to recover or heal don't occur in time. They tire, they fatigue, they run out of energy, they don't get the medical support, and then they go into a decompensated phase. This is your peri-arrest. Whether the primary cause is respiratory or circulatory, one is going to affect the other at some point in time. The difficulty is when you're dealing with a patient, a child, in cardiorespiratory failure in front of you, floppy, lethargic, unresponsive, tachycardic, tachypnea, shut down, delayed capillary refill, and so on. It's really hard to know, are they respiratory sick or are they circulatory sick? Okay. But nonetheless, if we don't do anything about it and we adopt a simple approach, then they will go into a cardiorespiratory arrest, given an amount of time. Okay, so let's have a look at this. The concept of respiratory failure. So compensated. Compensated refers to, and this would be an increase in worker breathing or an increase in respiratory rate and or an increase in worker breathing. Okay? Because not all tachypneic patients have a respiratory focus or problem. If you're shocked, your breathing rate goes up to try and improve the oxygenation and so on. But you're having a look at this. And compensated is that they're still maintaining an adequate level of end organ perfusion. They have a SAT that is adequate or within normal range. And pretty much that number that we're looking at is around about 90. Once we drop below a SAT of 90, typically, we'll regard that their respiratory system is failing, and so they're now a respiratory failure patient. Respiratory failure falls into 2 categories, type 1 and type 2. Type 1 respiratory failure is just simply a hypoxic patient. So a hypoxic patient whose DSAT, SATs are below 90, they're respiratory failure, or in respiratory failure, type 1. Type 2 is that same hypoxic patient with a failure to ventilate adequately. So their end-tidal, or their CO2 has elevated out beyond the 45 millimeters of mercury. And not only are they failing to oxygenate, they're failing to ventilate, and that's your type 2 respiratory failure. So type 1 respiratory or compensated respiratory failure, when we have a look at our patient, our child, we see that they have increased worker breathing or that they're tachypneic, and we're going to do a respiratory assessment, and part of that early assessment is SAT. And despite this extra worker breathing, this rapidity of breathing, they're still maintaining adequate oxygenation. So we have a problem, but they're still winning as far as maintaining what they need. When they're decompensated, this is where things tumble quite quick. You know, your oxyhemoglobin curves and how things, dramatically drop off and deteriorate once you go below 90. Things can get worse very, very quick, and it just then starts to spread as a systemic challenge to this patient. Okay. Decompensated respiratory failure can also occur if you are hypoventilating. So don't just think about a single respiratory figure or rate. or necessarily an isolated set of observations. Trending is really useful, okay? But also consider in any patient minute ventilation. So not only how quickly are they breathing or how slowly are they breathing, what's their volume status like? What signs of restriction do they have? You listen to their chest, do you hear wheezing? Do you hear equal air entry? Do you hear reasonable volume? Does it all sound normal? Okay, and you're gathering all of this information, and how does that fit to do with that? But bearing in mind again that a patient who, when you're trending them and they initially get sick and they're tachypneic, and they then start to decompensate, so they're going into respiratory failure and they're dropping their sat, and they're now becoming lethargic and switched off because they're becoming, the end organ dysfunction of hypoxia is starting to switch the brain off. And you come in at that point, and as their respiratory rate is descending down from 60 or 70, it will go, before it stops, through the 25, 20, 15. And if you hit them at that and I think, the respiratory rate's about 20, not too bad. Look at the context, look at the overall thing, is that, there are, in a floppy, unresponsive stuff there generally are no good vital signs from that perspective. So be very suspicious with that. And trending and repeat and reassessment is vital. Okay. Circulatory failure. So again, compensated and decompensated. A child with a compensated but respiratory failure is maintaining end organ perfusion. They're alert. They might be a bit irritable, but they're alert. They're switched on. They may be engaging with their circumstances in the way that a child for that age would do. You may pick up that they're tachycardic, but their blood pressure is often within normal limits. And they can do that because peripherally they constrict and restrict to maintain core perfusion better than adults will. And so a compensated circulatory failure are signs of peripheral poor perfusion, but essentially first snapshot is that they don't look too bad. And that's the thing, they don't seem too bad. What's gone on? And you do an assessment and you've got a pulse rate or femoral rate of 170, 180, and slightly delayed capillary refill to the knees. And that's a really big red flag and scary sign that we're looking at from there. But the child is still fairly alert, not wanting to cooperate with the strangers in green and so on, not wanting to be poked and prodded, scared of their surroundings and clinging on to mum. The decompensated circulatory failure is essentially your classic signs of shock, and this is where things are shutting down. And your flat, floppy baby who is got a rapid respiratory rate, looks a horrible colour, tachycardic, and delayed capillary refill centrally, from the circulatory aspect there is decompensated. They have not been able to maintain the perfusion their vital organs need. And so that's how you would tag those two, or at least communicate those signs. The decompensated circulator is a late sign, and cardiorespiratory arrest is shortly behind that. So, the focus with regards to, or the purpose of the circulatory system is obviously oxygen delivery to the tissues. And so that depends on the amount of oxygen getting into the blood and the ability of the blood to carry the adequate amount of oxygenation. So this is tapped into with your trauma patients, or if you have low hemoglobins and so on and so forth. You may not have a lung problem, but they are showing signs of hypoxia. Okay, they're breathing hard and their sat's poor and so on, but it doesn't mean it just sits with your respiratory problem. And also the ability of your heart to do its job and push that fluid out and around the tubes, around the body to get where it needs to go. And particularly in small children and infants, they don't, or it takes a while for them to develop the ability to pump harder. So what's open to them is just to pump faster. Okay? For us, adults, we can increase our rate, so we can pump faster, but we can increase the force of our contractility so we can pump harder. That can trick us sometimes for patients who are adult but young, in the fact that, well, they have actually lost a reasonable amount of blood or volume in the trauma, but yet they're not extremely tachycardic. They might be 110, 115. And that's not a reassuring sign, okay? But sometimes that middle grade of that class 2, class 3 shock can be really hard for us to identify in a trauma patient. So again, the individual's ability to try and compensate, can be misleading sometimes. Okay, so are you with me? Everyone on the same page? Happy with that? Does that make sense as far as compensated and decompensated respiratory and circulatory failure? Right. Okay, so you have your sick kid. So what are your bright ideas for managing initially as the initial responder? Now that it can be an unprepared child that's been brought into ED, a red call to an unwell child in the community. What do you really need when you do have, or apparently have, an unwell kid? What would you like around you?
Do you mean gear, Paul? Is that what you're...
Sorry?
Gear?
No, well, just in general. I mean, yes, okay, gear, we can talk about gear. But what's always nice to have when you've got troubling times? Backup. Okay, so having a team. Having a team and identifying what it is that you actually need to do to order our priorities with regards to that. And we'll talk about this just in a little bit with regards to ambulance specifically, how the ability to mobilize a child quickly can not always be an advantage for that child. So having a team approach is really important. When we don't have the numbers to allocate individuals, say 2 to airway and 2 to get a line in each and someone to assess and things like that, which is great, we have to linearly try and prioritize if there's just 1 of you, 2 of you, 3 of you. But what we do to try and actually still stay on track with regards to a focused approach is really important, and we can actually cover a lot of similar ground in a similar time if we're practiced and efficient. So we're going to follow through that A to E assessment, and whether the child is just irritable, hot, signs of crackly chest and coughing, or just flat and floppy in the mother's arms at the front gate as you pull up. Okay, so having a look at this video, what would you make with regard to an A and B assessment? And some of this is obvious. Okay, so state the obvious. What do you note?
Well, it's got an airway.
Okay, right. It's got an airway. Great. We start somewhere. Start with airway. Okay, so what sort of airway does it have? We'll call him a he. So you say he's got an airway. What else can you expand on airway? Is this a good airway? Okay, so what's the problem with position? Okay, so what are the problems with infants in airway position? Yeah, okay, so, but you're not wrong. He has an airway because he's alive and his eyes are open. The brain sort of, to a degree, is functioning there. But there's certainly concerns because, airway and breathing are closely related, and it's quite clear that he's doing quite a bit of work with his breathing. So when we think about airway, we think about upper and lower airways. But there's certainly a risk with regards to this, and particularly in infants, because their occipits protrude beyond the line of their back and shoulders. And so with their very small, soft tracheas, an infant placed on a flat surface can easily, and particularly if they become more somnolent, into a flexed airway position and obstruct, just because of their anatomy will make it easier to do so. So it's a good thing to pick up on that. But you're absolutely correct that, okay, here we have an airway. So let's talk a bit more about the quality of the airway. Upper, we've got risks, but at the moment, he's holding his own. Lower airway, and or breathing. What do we think from the video to do with that?